My name is Beth Stronach. Welcome everybody. We're here today because we're all linked through this cellular pathway, which is the RAS pathway. Changes in these genes, which encode the proteins in the pathway, have been linked to several genetic syndromes, which you probably are aware of, and they share various characteristics. So today we're going to learn specifically about and hopefully have a discussion on the hematologic or the blood functions and blood issues surrounding these syndromes. Our organization, RASopathies Network, was founded in 2010. We're a nonprofit volunteer advocacy organization run by parents of children with genetic disorders of RAS signaling. Our mission is to advance research to improve the quality of life for RASopathies families by bringing together families, clinicians, and scientists. RASopathies are syndromes caused by mutations in genes that result in excess RAS signaling activity during embryonic development and throughout the lifespan. We have a small organization. We have a board of directors with 5 of us currently. We have a scientific advisory board and an advocates advisory board, and we're always looking for volunteers to help out and support our mission. Our website is shown at the top here, rasopathiesnet.org. And if you navigate to the website, you can find things about the syndromes, about current scientific or family organization meetings, and also under resources, you can find the webinar links for our previous webinars that we've held. One of the really popular ones is on vaccination for individuals with RASopathies, so you can find that there. Also, we have research studies listed and many other resources. We're involved in several different campaigns, one of which is the $1 Million Bike Ride, and that just took place last weekend. It actually provides an event to raise funds for research grants to advance understanding of the RASopathy syndromes and how they affect the human body, with the hope of identifying better care solutions and better therapies. And we're also interested in raising awareness through open communication and partnerships with the syndrome family support groups, shown here through our social media channels, and by developing clinician and researcher networks. So the $1 Million Bike Ride was actually last weekend, and if you don't know about it or you haven't participated, it's a really fun and meaningful event. There are actually many rare disease groups that partner with University of Pennsylvania or Penn Medicine and the Orphan Disease Center. And they put on this event and they raise funds for their respective diseases. Next year is going to be the 10th anniversary, so hopefully it'll be a really big event. You can keep that in mind for next summer, and you can actually participate by riding, either in Philadelphia or where you live, and you don't have to ride. You can also be a virtual rider and volunteer in other ways. So if you'd like to get involved, keep that in mind. And we are still accepting donations through June 30th for this $1 Million Bike Ride event. Here are just a few pictures from last weekend. Me over in the left-hand side and Lisa Scheuer, our president, in the right-hand upper corner. And that's actually the water stop or the volunteer stop where the bikers go midway through their journey. And I just wanted to point out that we've actually been participating in this event. We've been able to award through generous donations from our supporters over $400,000 to fund 8 projects by 8 different scientists over the last 8 years. So I really want you to think about, we need to value and we need to support the research if we want to continue to improve recognizing these diseases, diagnosing these diseases, treating them, and providing support for all the RASopathies. So I think it's a really important consideration for pushing the field forward and to advance research and treatments. I'll just mention that we're going to have a symposium next summer, And some of these MDVR funded projects will be highlighted by the researchers that we've funded, so you can find out more next year. Lastly, we'll mention that we have a contact registry where you can add your name and some other demographic details. We sort of keep that in order to be able to contact you or to let you know about things that the organization is doing and also research studies that are ongoing. So on behalf of RASopathies Network, we thank you for joining us today, and we'll get to the main event, which is to feature two hematologists, Dr. Anjali Pawar from UC Davis and Dr. Benjamin Briggs from Rady Children's Hospital and the NavalMedical Center in San Diego. So welcome to you, and I will turn it over to Dr. Pawar.
Thank you. So as I was preparing for this talk, it took me a while to realize that bleeding disorders in patients with RASopathies is something that is not very frequently brought to the notice of a hematologist. Next slide. There is a disclaimer. I'm on more than a couple advisory boards and have some research grant from various pharmaceuticals. But I will not be using any specific products in my discussion today. Next. What I hope to cover today is what is my role as a hematologist. I'm a pediatric hematologist, and most of the bleeding issues that do occur are under 18 years of age. For example, adolescents and young adults or toddlers, the busiest children group in the world. They get into all kind of risky situations, and it's very, very concerning for parents to find out that it's possible that just because of their syndrome, the child may have a bleeding disorder too. I also hope to do a high in the sky, not Top Gun Maverick high sky, but at least up there view of the components of the bleeding and bruising and how they help us understand the test and also the treatment. These are done by doing screening tests, and there are limitations. These are screens after all, and once the screening test is normal or abnormal, it can help us navigate what to do next. So we do have limitations, and there are things that screening tests cannot tell us. This will also help to understand the treatment of bleeding disorders, like I said, and collaboration for further research. I was really impressed by one of your slides, Lisa, where you had so many logos of different societies that you work with. And I'm hoping that by the end of today's talk, we can add a few more to that slide of yours. Next. You did a great job of telling what is RASopathies. It's like an umbrella term for genetic mutations during the fetal stage that result in overactivation of RAS protein. There are so many syndromes, I'm not even going to name them, but all I wanted to say was that there are still other disorders that are emerging as our technology to understand the pathways and the cell molecular conditions get more and more refined and more advanced. Next. So we all know, as parents, you know what is a RASopathy. We know that there are many different conditions that your child is seen for. They see a PCP, they see a genomics or a genetics department, they may need neurology, they may need cardiology, endocrinology, oncology, ophthalmology, developmental medicine, sometimes surgery, and gynecology. Those are a lot of logies or a lot of specialties that are involved in taking care of your child. But the one name you don't see over here is a hematologist. So it's not automatic for a child or an individual who has been diagnosed with RASopathy to see a hematologist. So when does a hematologist get involved? So any of these providers that you see on the left-hand side, if any of them have a concern, or the parents who are the biggest advocates for the children have a concern, they will be referred. So we are a referral service. We don't automatically get involved in your child's care. But if you get a referral to us, that is when a hematologist gets involved. And it's pretty exciting. Next slide. Because hematologists are basically Sherlock Holmes. We put on our Sherlock Holmes hat. We don't use the pipe, of course, but still, we go through and try our best to understand what is happening to this balance between the bleeding and clotting that is termed as hemostasis. Heme is blood, stasis, it stays in a balance. So in our body, the blood is constantly in a liquid form. The heart is the pump that shoots all the blood through the vessels, which are closed pipes. And the interaction between the platelets, the vascular wall, and the coagulation protein forms the basis of hemostasis. Any of these players, including the blood flow and the shear flow, of course, if any of these get out of range, then we are in trouble. For example, the platelets need to adhere properly. They need to get activated properly, secrete their granules. They need to stick together, aggregate, so not only adhere, but aggregate, and then they get the coagulation cascade going. The vessel wall also has its role, like I said, next slide. So in our body, this is just a picture or a caricature. No, it's not a caricature. It's a picture of how the jungle of blood vessels looks. It's literally a whole, it's like cables, or it's like closed pipes that originate and enter the heart. So the oxygenated blood is pumped out of the heart through arteries, and the less oxygenated blood comes back to the heart through veins. These blood vessels become thinner and thinner and thinner, and at the end, if you see the third little figure on the left-hand side of the screen, this communication is actually 1 cell thick. You can imagine there are areas in our body, in fact, majority of the areas in our body have blood vessels that are just 1 cell thick. And it's very easy for leaks to spring in these blood vessels. And when they leak, they leak blood. And that is how we get bruises and the petechiae. So this is the closed vessel system that conducts the blood. What about the blood itself? It's not just fluid, of course, all of us know that. It's composed of zillions and zillions of cells. There are the red cells, millions and millions of red cells. They are the ones that give the blood the red color. These are the cells we talk of when we're talking of anemia, iron deficiency, all that kind of thing. But they are not directly involved in bleeding. Then we go to platelets. If anyone can see those tiny little didzels at the end of the arrow, the second arrow, those are actually platelets. And body is constantly making and recycling these platelets as well as red cells. The red cells stay in your body for about 120 days, normal red cells. Platelets, on the other hand, have a lifespan of about 7 to 9 days. So you can imagine how frequently the body has to keep making new platelets and recycle the old ones. Those white cells, although they look colorful, they are colorful because they have been stained, so we can see them under the microscope, but there are different types of white cells, and their job is mainly to protect you from infection. So out of all these components of the blood, the main things that are involved in bleeding and thrombosis is platelets and the plasma. Plasma is the background colorless liquid that you see on this slide. Next slide. What is the current understanding of how the bleeding is controlled? We think of blood vessels as closed pipes, right? So whenever there's a breach in the wall, as you see on the top of the first figure over there, it needs to be plugged immediately, or it needs to be taken care of immediately. Otherwise, all the liquid blood in our body is just going to flow out. The first reaction is vasoconstriction. The blood vessel actually acts like a physiological tourniquet and does the function of a tourniquet. It constricts, it narrows the surface, and it pushes some of the blood into that breach in the wall where the platelets form a temporary plug. The platelets adhere, which is one of their jobs. They stick to this site of injury and they form the initial plug. As they are getting to this site of injury, they are not the round, beautiful little platelets. They are getting very, very activated. As you can see in that electronic photograph on the right-hand side of the slide, the platelet has gone through activation. It spreads out, so the surface increases. It degranulates. Platelets have active granules and molecules. Those are released, and they do. It also helps in vasoconstriction. So it's activation of first vasoconstriction, then activation of platelets and adhesion. The platelets adhere to that breach in the wall. Simultaneously, on the surface of platelets and also some proteins in the plasma, they work together in a cascade fashion. Now, whenever anyone goes on internet and looks for the word bleeding and coagulation, the first thing that comes up is the term coagulation cascade. And why is it called a cascade? Because the upstream, the initial amount of protein is very small, that then activates a larger amount of protein and larger amount of protein and larger amount of protein. So there's a cascade effect. All these proteins, they get activated and they form a plug, which is more firm than the one made by the platelets. And this plug of proteins is called the fibrin plug. This will become a little more clear why I'm giving this background with our next slide. So think of formation of the clot to stop the bleeding, like a 101, is that there's a resting platelet, breaches the wall, becomes activated, and in the meantime, as it is getting activated, forms like a plug. It's a temporary plug. Then the proteins go into action. They it's like a think of it like a symphony. All the proteins, there are so many proteins in our blood. They act in a very concerted fashion. And in the end, form a fibrin clot. So the two main important proteins are going to be thrombin and the fibrin clot. Fibrin clot is the one that stops the bleeding. It stays in its position for a longer time and is able to control the bleeding. Now, you can't have a clot permanently. I mean, it can't spread throughout your body and form a jello. That won't work. We need blood to be like a liquid. So this is very specified and very local thing that happens. The clot is something that is formed only locally wherever there is breach or break in the vessel wall. So the clot has to be broken down too. And things can go wrong at many of these steps. Next slide. So since looking for a problem in this whole big, long spiel of clotting 101, how do we hematologists test you when a patient is referred to us for a possible bleeding disorder? We run screening tests. So we bunch them for platelet activity. We look to see the number of platelets is normal. First thing, we need to have a normal number of platelets. We need to test whether they're functioning okay. So there's activity, platelet activity testing. If anything comes abnormal in that, then we check for platelet aggregation. Do they aggregate like they're supposed to do? We also can check for something to look for the protein. Are the proteins working properly? Now remember, these proteins are some in the plasma, some in the platelets, some in the vessel wall, so they're all over the place. But the screening tests will tell us whether they're all acting together or not. And these tests are called the PTT, the INR. If there's anything abnormal in the first two, then we do what is called as mixing studies. So we mix the patient's plasma 1:1 volume with normal plasma. And the hope is that the normal plasma should normalize the plasma that is being tested. Because if you test a plasma that is deficient in something with a normal plasma, it should correct whatever was deficient in the initial plasma. So the mixing studies, once we know that the mixing study is correcting or not correcting, then we go looking for individual proteins, which are a myriad of them. Look for individual proteins, which is a pretty delicate task to do, and see if anything is missing. Now, if all these tests are normal, then patient is still having bleeding problem, then we do a second tier and third tier testing, like we check for thrombin time, plasminogen activating inhibitor 1, PI1 testing. These are pretty selective tests, and they're not necessary for everyone, because the first tier testing, the platelet function, the PTT INR, these give us 90% of the results. So all these tests should preferably be done in a specialized coagulation lab as far as possible. I'll tell you why. Let's go to the next screen. The why would a patient come to us? It would be for something like a nosebleed, which should stop. If you see on the right-hand side, the blood vessels in the nose, if they bleed, they stop. If you don't have a bleeding disorder within a certain time, X amount of minutes, it stops. But if you see the same figure on the right-hand side, you see that the nosebleed continues to drip, drip, drip if your platelets or your proteins are not adequate. It'll take a longer time. It can take up to hours for the nosebleed to stop. So there has to be first a trigger, and then that trigger just exaggerates the symptom. Same thing, for example, a dental extraction. Normally, any bleeding from dental extraction should stop within certain amount of minutes, or maybe an hour or so. But if you have a bleeding disorder, you can end up with a dry socket. Another example of what you see on this slide is petechiae, and there's an animation on it. Yes, this is what I meant by saying petechiae. If your communication vessels are single cell thick, blood can easily leak into the surrounding tissue, and that's how you get those petechiae. Then adolescents, sometimes the first challenge for any kind of bleeding disorder can be their periods. That's the first time they are challenged. And instead of the menstrual flow stopping, the blood vessels that you see in the right-hand side of the two pictures, it should stop the bleeding within 4 to 5 days, which is considered normal. But if you have a bleeding disorder, you continue that action doesn't happen, and you continue to bleed either for a longer time, or during the first 4 or 5 days when you should have like 3 to 4 pads, you end up having 10 pads. So this does take you to a hematologist. Using the same figures that we use to understand the screening tests and the components of the coagulation system, it can also help us to understand the treatment. We can protect the platelet functioning by avoiding medicines that are called as non-steroidal anti-inflammatory drugs, which is like Motrin or ibuprofen, Aleve, those kind of medicines. Now, if an adult is on aspirin, there's a reason that adult is on aspirin. They should stay on aspirin and have a discussion with their cardiologist or hematologist. But generally, if you're not regularly on NSAIDs, I would say the first thing you do when you see a bleeding symptom is check your list of medications. And if you're on any of these NSAIDs, they're messing with your platelets. And if your platelets are not functioning properly, you're going to have some bruises and bleeding, unexplained bruises and bleeding. If your INR or PTT is out of range, you do the mixing study, and we find out that there are some proteins. Proteins are called as factors in the coagulation system. So if any of these are low or missing, you can do a couple of things. You can administer a medicine called DDAVP or Stimate, which can be a nasal spray or a subcutaneous injection. And what that does is brings the stored protein into the circulation. Body has stores of everything, including the proteins that are needed for coagulation. And sometimes that is enough to control the bleeding. Or if that factor is really, really low, when I say factor, it's protein, is really, really low. Many of them, we have recombinant proteins, which can be given as an IV infusion. In case of emergency, we just give patients plasma because that has all the necessary proteins in it. So there are ways of managing bleeding if you're missing a factor. Or if it is a minor kind of bleeding, like a nosebleed that doesn't stop for 1 hour, and we know the patient has a minor bleeding disorder, you can keep the clot on instead of letting it get dissolved by the natural forces of medicine, physiology in the body. You can prevent the clot from dissolving early. And the most common medicines used for that are Amicar or aminocaproic acid and Lysteda, which is, forgive me, I forget what is the pharmacological name for it. You can try these medicines too, and they're given oral. They're available for children as young as babies. They do cause some GI upsets, but basically they're relatively benign, and they can give you the benefits for short term till you see a hematologist and sort out what's going on with their child or teenager or adult in the family. Next.
Sorry, let me see it. There we go.
So as part of preparing for this presentation, I tried to do a lot of literature search. Like I said, I'm a pediatric hematologist. And generally, we see patients once they're referred to us. And I was wondering, how come in my practice, we see a lot of patients with hemophilia, with von Willebrand disease, and platelet dysfunction, so many patients, but I don't remember having a large number of patients with RASopathies. So I went to the literature and did some research on it. Dr. Briggs is going to give you a way more information than I am going to give you here. And there is more and more literature coming out that RASopathies do have hemostatic abnormalities. These can show up as abnormal screening tests, or this can show up as surprises. And we need more research. We need advocacy. We need your support in helping us understand, because I had more questions than I found answers. So today what I'm saying is, yes, we need to advocate that patients with RASopathies should be evaluated for bleeding disorders. And also, next slide. Let me hand over to Dr. Briggs now so he can tell you what we know, what's available in the literature about the knowledge about this population. Thank you.
Yeah, thanks, Dr. Pawar. That was great introduction to the potential presentation of bleeding symptoms, as well as how it would be worked up for what could be causing it. I got interested in this topic through a personal experience in parent advocacy for one of their patients, or one of their children, excuse me, was my patient. And the child was going to have surgery, and the mother brought to me some references and referrals suggesting that patients with Noonan syndrome could have bleeding complications. I'd never heard of Noonan syndrome before, nor was I aware of the potential link with bleeding disorder. And from that experience, I've been interested in understanding this better and helping advise families and patients regarding this question. So, you know, the recommendation for screening, there's been recommendations for the past 10 years. And certainly one of the outcomes that we would like to avoid is a postoperative bleeding complication as the presenting symptoms of a bleeding disorder. So if you can go to the next slide, it's important to remember that the bleeding disorders that these patients have are often mild severity, and so would not present with the type of symptoms that such a patient as with hemophilia may have with spontaneous bleeding. Oftentimes it takes some sort of injury or surgical procedure to bring out the bleeding symptoms. Also, there is often a combination of bleeding disorders. So it's not usually just one problem, such as platelet dysfunction, but usually it's a platelet dysfunction and a mild deficiency in one of the factors. And so you often need to take a more comprehensive approach in the workup of these patients than you may otherwise. There's been a ongoing question about genotype-phenotype correlation, and at this stage, there's not a clear correlation that's been described. However, the Noonan syndrome umbrella phenotype seems to be more associated with the bleeding complications than the other RASopathies. There certainly needs to be more data on that. And then, you know, certainly these patients also do require surgeries frequently. And so obtaining testing up front would be a logical approach. All right, you can go to the next slide. So this is a retrospective analysis that we did, essentially looking at what the impacts of such a screening approach, such a bleeding workup, might prevent in terms of bleeding complications. And what we found was that if patients had a workup that was done that was negative for any bleeding disorder and had surgery, they didn't have bleeding complications. If patients had bleeding complications, essentially, those patients would have been detected with appropriate screening and bleeding workup. Next slide. And this was from an earlier paper that really highlighted to me the importance of kind of thinking about all aspects of the coagulation and fibrohemolytic cascade, really showing that a lot of patients may not be detected if you're only doing one screening test, and that you really need to take into account the laboratory results and the patient's bleeding symptoms to really be able to determine if this patient would be at risk of having bleeding complications or not. Next slide. So this is a question that we also get a lot. Could it change over time? And I think the answer is we don't know. I think it's intriguing to think that it potentially could. Certainly, we're dealing with a molecular pathway that's involved in cell growth and differentiation. So it's possible that it could be changed and modified. And I think it'd be really fascinating to see how a patient's bleeding symptoms may evolve if they're placed on a MEK inhibitor, perhaps for another reason. And so I think as we move forward into these fields, really having this as an additional question that gets asked and potentially answered would be important. Next slide. So, you know, in terms of bleeding symptoms, now these do take some time to develop. So a newborn child is not going to have had the test of time, so to speak, to be able to present with these symptoms. But certainly you can find a strong correlation between the presence of bleeding symptoms and the potential bleeding complications that could develop regarding surgery. And so if bleeding symptoms are present, I think absolutely those patients need to have a workup performed. Menorrhagia in this study wasn't able to have as strong of a correlation, particularly because we didn't have as many patients who had that issue. Next slide. So just kind of reviewing those symptoms again, easy or excessive bruising would definitely be something that would warrant further workup. If you have large bruises with vaccines or hematomas, which are basically raised bruises, definitely those would be considered abnormal. Next slide. And then nosebleeds is another common issue. So if you're having, 10 nosebleeds a year, they're taking greater than 10 minutes to stop bleeding, you're having to take someone to the emergency room to get it to stop bleeding, those would all be abnormal nosebleeds. If it's just one nostril, stops with a little bit of pressure, and seems to happen, triggered by something such as, a bonk on the nose or really dry weather or allergies, those would be less likely to be associated. Next slide. And then, so again, kind of touching back to the menorrhagia, sometimes young women may not feel super comfortable talking about their menstrual cycle and the quality of it. And so sometimes actually using pictorial diagrams would be really helpful in quantifying the amount of blood loss and defining whether it's abnormal or not. And next slide. And then the other symptoms that we were already touched on, certainly petechiae, gum bleeding is another one I see a lot, particularly if you're platelet function defect. Severe bleeding with tooth loss. So that's another one I see a lot in patients with Noonan syndrome is they lose a tooth and it just takes forever for the tooth loss to stop bleeding. There's bleeding when the umbilical stump falls off. That's like soaking through a onesie or something like that and making a large pool of blood. That would be definitely abnormal. Postoperative bleeding or bleeding complications after a circumcision. Next slide.
So I was able to put in those slides from Dr. Briggs. I don't know if you want to summarize some of your findings, but this slide basically is a recap of some of what we've talked about, hopefully some of what our attendees can learn, as well as important questions that have come up, some of which have been addressed. Do you have any other summary statements to talk about, Dr. Briggs?
Yeah, thank you. I think there are still a huge need for ongoing research to better answer these questions. Regarding the recommendations for bleeding workup, that I think needs to be balanced against the age of the child, if there's upcoming surgeries or not, and how much blood needs to be taken to perform an adequate evaluation to suggest that you've eliminated the risk for a bleeding complication or not. And so I think for that reason, having a hematologist involved would allow for that conversation to happen in the office with someone who's very experienced in that and can answer those questions most effectively. I don't know if you have anything to add to that, Dr. Pawar.
Yeah, actually, I do. So most of the academic institutions have special coagulation labs, and we see there's actually literature out there that when the tests are not done at the special coagulation labs, they can be misleading. That's because if they're drawn, if they're shipped and then tested 3 days later, the proteins are going to be broken down by then, and we can get misleading results. So as far as possible, to pick up these kind of very subtle bleeding disorders, I would advocate that all testing be done at special coagulation lab, and that's where you'll find the hematologists too.
Perhaps we can go to the, you have a list of organizations here that also provide information about hematological issues, and then we can open it up more broadly for questions and discussion.
Yeah, so American Society of Hematology, it's an international, it's called American Society of Hematology, but they have members from all over the world, all over the country, of course. And they have got a very active hematology research, bench research, clinical research programs and grants. So it is one society which I would strongly advocate. Foundation for Women and Girls with Blood Disorders. It's a relatively newer foundation, maybe 10 years old as your network. But if you see that little image on the right-hand side of the slide, it's a map. And the map is for so many centers, they're called centers of excellence. And these are run by the hematologist and the gynecologist or adolescent pediatrics. So someone who is an expert in the gyne part of it, gynecology part of it, and someone who's an expert in the hematology part of it. They combined clinics and they're offered at, I think last count was some 78 centers across the country. They are wonderful resource. And if you're able to reach them, they have a website too, and there's a lot of information on that website. The International Society of Thrombosis and Hemostasis, of course, the name is self-explanatory, and they're very interested in research and finding, correlating the genotype, phenotype kind of questions. So the American Society of Hematology and ISTH, I think personally, these are the two main societies we should collaborate with. Dr. Briggs, what do you think?
Yeah, absolutely. I agree. I think they would be great organizations to help answer some of these questions. Definitely.
For example, ISTH has a bleeding assessment tool, which is a validated tool. It's a questionnaire. Anyone can download it from the website. There's an ISTH website. You can download it, fill it. It gives you a numerical value for your bleeding symptoms. Take it to a provider and ask for a referral to a hematologist.
Great. Well, I think I appreciate both Dr. Pawar and Dr. Briggs presenting on this. I'm going to stop sharing the slides and then we can sort of hopefully open it up more generally if people want to ask questions or discuss any of these issues further.
One of the points that Dr. Briggs brought up was very important. You know, he said that age appropriate, because hemostasis is developmental. So the tests and the results that you see in a 1-month-old or a 3-month-old will be very different from what you see in a 1-year-old. So it is possible to get testing done too early, and then those don't apply to the child's rest of the life.
Mm-hmm.
And also the amount of blood you can draw from a child, that is also another thing.
Right.
So that's where you need a hematologist.
Yeah, I believe that there are in the DICERN guidelines for NS and in some of the lay literature as well as on the Facebook groups, people talk about it a lot. So I think there is some awareness that parents have for this. But I've also seen people express that they have gotten some tests and they've come back normal. And so then they're not aware that there might be a problem in the future until something happens. So
Yeah, so I would still recommend that please request the testing to be done at the special coagulation lab in an academic center where everything is done very immediately. There is nothing lost in transportation and shipping and handling. So if you have mild dysfunction with platelets, especially, it can take a multiple testing to get to a conclusion.
It's hard for doctors to justify the multiple testing when the typical thing always with the Costello I know is everything is within normal limits, and yet there,
Mhm.
you can see there's a problem. So
Yeah, yeah,
Yeah,
yeah.
and
Yeah, and I
some,
think to that point, oh, sorry, go ahead.
no, go ahead, Dr. Briggs.
Yeah, I think what you guys are describing is something that is seen in discussion with the families and patients, and it's also reflected in the medical literature. In that, if when people were doing testing and they just found a patient with von Willebrand's and they stopped there, they may assume that
Hmm.
that von Willebrand's was the only issue. But in
mhm.
fact, I think what we're seeing as more comprehensive testing is being done is that there's often more than one issue present. And
Yeah,
so I think for that reason, in consultation with a hematologist, someone who can have this discussion about your 14-month-old saying, you know, it's going to be a lot of tubes of blood. There's no surgery upcoming. We could keep an eye on this really closely. And then when they're older or if there's surgery upcoming, we could do the testing. That might be an approach I might take. But I think at some point, doing a comprehensive evaluation is going to be the best way to get to a definitive answer and potentially more than one answer.
That's a great point. Thank you.
I know
and
there
that's
were,
also,
sorry, a few other people were concerned about different things in the blood that were higher or lower than normal. So hemoglobin was one, cholesterol was one, white blood cells was another one. So is there any sort of best practices or standards of how, you know, what to look for or what to do if you find that one of these components is up or down? Or is it sort of not generalizable?
I would say it's not generalizable. Um, it's so age dependent and so much like you could have anemia got nothing to do with bleeding disorder. It could be
Mm.
something else that is causing anemia. And white blood cells, as a hematologist, those are some of the most dynamic cells in the body that go up and down for at multiple triggers. May not have anything to do with bleeding.
Yeah,
But
I would agree with that.
mhm.
Yeah.
Are there any particular special concerns since Noonan syndrome can be at risk for JMML, which is a blood cancer, right?
Yeah. So in fact, in oncology is where we are more familiar with patients with RASopathies than in hematology. So we are always aware that anyone with Noonan syndrome should be monitored, just like a child with a Down syndrome should be monitored for hematological malignancies. And the suspicion for JMML will be higher in a child with Noonan syndrome than it would be for a non-Noonan syndrome child.
Yeah, and the white blood cells, if reviewed under peripheral blood smear, would be detected as abnormal appearing in like a JMML, as opposed to if it's a reactive process, that you would expect them to be more normal in appearance.
Right.
Are there specific factors? I've noticed that some where people have identified where they have a factor deficiency. I've seen factor 13 several times and factor 7. Are these I guess we had sort of talked about this before. Is there any relationship to RAS signaling and these factors, or is this something that just happens kind of in a random way that may come and go? or why is it specific to certain factors?
Such a good question.
Yeah, I don't think we know that yet. Certainly, it does seem like there's a link that they've been able to show, at least for platelet function defect, that the RAS-MAP kinase pathway is involved in some of the platelet signaling, and increased activity of that signaling could be actually part of the abnormal function of platelets. How that may be involved in the hepatocytes that are making the clotting factors would be a very interesting question to look into as well.
Okay, maybe something for a future MDBR research grant. If Noonan syndrome, children with Noonan syndrome or any of the other syndromes are going to go to the dentist just for a routine cleaning, do they need to be concerned? Or is it that you really would have some indication ahead of time that you would need additional treatment factors?
So gently, there's not going to be any, I'm sorry, go ahead, Dr. Briggs.
Sorry. Yeah, I think you were going to say the same thing I was, that if it's just a cleaning, probably you're going to be okay. Yeah.
Okay. Or if you had bleeding in the past, then you can keep some Amicar with you.
Okay. Yeah.
It's mainly extraction. So wherever there's the surface, the mucosal surface is disturbed, where we are concerned about bleeding.
Okay. Are there any other pressing issues that people want to discuss? We're sort of near the end of our hour.
Yeah, I just wanted to comment on Rosemary's kind of questions. Depending on what has been done in the hematology workup, what we find with patients with Noonan syndrome, and again, CFC and Noonan, I think there could be a link there, and some of those patients may have bleeding issues, but for a comprehensive evaluation, I would consider doing platelet, function testing, platelet aggregation, full factor cascade, including factor 13, and the von Willebrands. That's quite comprehensive. If those have all been looked at, then you're really starting to get kind of reaching into like some of the other like Pi1 and things like that. But at least those three main categories. I don't know if you'd add anything, Dr. Pawar.
No, I agree. Just my little thing about getting all the testing at a special coag lab, please.
And how do patients get referrals? Like, would it be through the genetic counselor or through their pediatrician or regular PCP?
Anyone can refer to us.
And is it typically covered by insurance?
Yeah.
Okay, that's good to know. Where do you think if we were to support research or even advocate for more research, what would be sort of the top 3 directions that you think would be most informative?
I think educating the different physicians who take care of Noonan syndrome. For example, I was talking to a cardiologist. We have a very robust pediatric cardiology program and cardiothoracic program too. And just talking with them and asking if they're aware that they take care of a lot of children with Noonan syndrome. And at least she said she has not, as far as she was aware in the department, they didn't have a list of patients with Noonan syndrome with bleeding disorders. But then if the patient was going to go for surgery, they should have at least screening tests done. Same thing with geneticists. Same thing with say neurology or surgery. Surgery, it is easy because it is just their standard of care that before any child goes for surgery, I'm so sorry, Rosemary, to hear about your child, should have screening tests at least done. And if they know that the child has a predilection like a RASopathy, then they generally send them to us, to hematologists.
Okay.
I think questions that, you know, I would think would be really helpful to the community too would be, how could this potentially change over time for patients? Is it a static process, or does it, you know, change? And I think there's the potential that it could change, particularly again, especially with patients starting to get on MEK inhibitors. I think that would be a very interesting question to have answered as well.
Do you know if anyone's looked into that in your reading of the literature, like in preclinical models even? I'm not sure.
Not that I'm aware of, but it, you know, certainly there could be out there. I just haven't come across it yet.
I guess, has there been an animal model that has shown the hematological issues that have recapitulated it, that you're aware of? As a model system to study some of these questions?
Not that I'm aware of. The last time I tried to go digging was maybe 18 months ago, but yeah, no.
Well, maybe that's something that could be brought up as well.
And I have to confess that it is only now that I'm looking into learning more about RASopathies and bleeding disorder.
Yeah. Okay. Well, I want to thank both Dr. Pawar and Dr. Briggs for a really interesting and insightful presentation today, and for our attendees who participated and asked questions and discussion. I hope you found some of the answers to your questions and some of the resources that you can use to look into these issues further.
One last thing, can you repeat the 3 tests again? Sorry.
Yeah, that's all right. So platelet aggregation studies, or which looks at platelet function, and then factor deficiencies. And oftentimes how that's carried out is by doing the PTT test. And so if one of those is prolonged, then it would give a certain set of other factors that need to be tested. The one exception to that is the factor 13. And then von Willebrand's disease testing is also not going to be detected on that either. So those 3, the platelet function, the von Willebrand's, and the clotting factors.
Thank you.
I have a question for the organizers.
Yes.
Is there any way of finding out how many of the AYA population, that is adolescents and young adults, especially females, have problems with menstruation?
I mean, it's definitely something that can be posted as a question on some of the closed social media groups.
With Costello syndrome, what's not uncommon is delayed puberty. So
Delayed puberty.
that's
Okay.
but we can certainly ask about how the flow is and all that stuff.
Because generally what happens is, if you go to a PCP, primary care provider, and say that the periods are heavy, they may not be able to put 2 and 2 together, that your syndrome may be causing some bleeding disorder, and patients may just get put on hormonal therapy.
Yeah, so I think, I don't know if you mentioned this specifically, but not just the heavy bleeding part, but whether whether it causes irregular, or say not monthly, right? Irregular cycling. Is that part of it as well?
Not directly, but there can be something what is painful cycles too. That also can be a red flag to look for some bleeding disorders.
And if you have your diagnosis and you have a blood workup when you're very little and you're a girl, do you need to do it again when you're going through puberty?
If you have a diagnosis and had a bleeding workup, it makes sense to repeat it when you're a teenager, I guess, or an adolescent.
especially if you're having problems, I would think, yeah.
And things can change. We don't know how dynamic or static these changes are.
I think again, having a balanced approach to it, I think is very reasonable in that, you know, getting 7 tubes of blood to get the answer now, if there's not severe symptoms, I think it would be okay probably to wait if there's not upcoming surgery to get the final answer. If that makes sense.
Thank you so much for joining us.
Yes. Thanks,
We'll go
guys.
ahead and
you.
stop recording and